Hi, Dr. Brazier here. Welcome to this video presentation about depressive disorders. In this video, I'll attempt to review what you've already learned in your abnormal course about the symptoms that make up this syndrome of depression. And I'll also briefly review what we know about etiology, what tends to sort of predict or cause depression. So let's get started. Okay, so according to the DSM-5, a major depressive episode includes at least 5 of the following symptoms lasting 2 weeks, and one symptom has to be dysphoria or decreased interest. So dysphoria, depressed mood, subjective or observed, decreased interest or pleasure most of the day, nearly every day, change in appetite, increased or decreased greater than 5%, change in body weight in 1 month, change in sleep, so either hypersomnia or insomnia in the initial, middle, terminal, nearly every day. Psychomotor disturbance, so slowed or restless or agitated, observed by others. Decreased energy nearly every day. Feelings of guilt or worthlessness. Impaired concentration, and thoughts of death or suicide. The major depressive episode has to cause significant functional life impairment, and it cannot be due to a substance or a medical condition or to any other mental disorder. So one easy way to remember what a major depressive episode looks like is the mnemonic SIGGY caps. So S is for sadness or decreased interest, I is for interest decreased, G is for guilt or worthlessness, E is for energy change, C is for concentration impairment, A is for appetite change, P is for psychomotor retardation or agitation, S is for sleep disturbance, and the next S is for suicidal thoughts. Other symptoms of major depressive disorder that didn't make the DSM-5 list include crying or tearfulness, low libido, hopelessness, helplessness, and decreased self-esteem. Modifiers for a depressive episode include single episode versus recurrent. Other modifiers can include mild, moderate, or severe, psychotic features, in partial remission, or in full remission. You can also have with anxious distress, with mixed features, with melancholic features, with atypical features, with mood congruent psychotic features, with mood incongruent psychotic features, with catatonia, with peripartum onset, and with seasonal pattern. So you can also add the following modifiers: melancholic, psychotic, catatonic, which is going to involve some extreme physical immobility or excessive peculiar movement, atypical, peripartum onset, and with seasonal pattern. We'll look at each of these. So melancholic is a severe type of depression, and it involves terminal insomnia, basically early morning waking up, anorexia or loss of appetite, non-reactive mood, anhedonia or like the inability to experience pleasure, excessive guilt, diurnal variation in mood, which means that the mood gets worse in the evening and better in the morning, and marked psychomotor retardation, which would look like a person who is like super slowed down. And then psychosis and depression can include hallucinations or delusions that are usually mood congruent. These often have morbid or persecutory themes, including guilt, disease, or death. So then atypical depression does not mean that it is uncommon depression, but it does include hypersomnia, hyperphagia or increased appetite, mood reactivity, long-standing interpersonal rejection sensitivity, and leaden paralysis. So depression with peripartum onset means onset within 4 weeks after childbirth. 50% of depressive episodes begin before delivery, and then there's a 30% to 50% risk of recurrence with subsequent pregnancies after. Infanticide usually occurs with postpartum psychotic episodes, so 1 out of every 500 to 1 out of every 1,000 deliveries. And there's an increased risk in prior history of depressive or bipolar disorder. In order to meet criteria for major depressive disorder, a person must have experienced 1 or more major depressive episodes and have no history of manic, mixed, or hypomanic episodes. That would be bipolar. So persistent depressive disorder, otherwise known as dysthymia, is a depressed mood lasting at least 2 years and including at least 2 of the following symptoms: insomnia or hypersomnia, decreased appetite or overeating, decreased energy or fatigue, low self-esteem, problems with concentration and decision-making, and hopelessness. It causes super duper impairment in life functioning. And of course, there can be no manic, mixed, or hypomanic episodes. There can be no major depressive episode in the first 2 years. However, people with persistent depressive disorder are at risk for future major depressive episode and disorder. 10% per year develop it. Experiencing a major depressive episode after having persistent depressive disorder is sometimes termed double depression. People who meet criteria for premenstrual dysphoric disorder have at least one of the following: marked affective lability, so mood swings, marked irritability or anger, increased interpersonal conflicts, marked depressed mood and hopelessness, and marked anxiety, tension, like feeling on edge. They also have one or more of the following to reach a total of 5 in combo with criterion A. So decreased interest in usual activities, concentration problems, lethargy and easy fatigability, change in appetite like overeating or food cravings, hypersomnia or insomnia, feeling overwhelmed and out of control, and physical symptoms including breast tenderness, joint or muscle pain, bloating, and weight gain. In the majority of menstrual cycles, the woman must have at least 5 symptoms present in the final week before onset of her menses, and it must start to improve within a few days after the onset of menses and become minimal or absent in the week post-menses. Okay, so another diagnostic option is mood disorder due to general medical condition. The mood disturbance is judged to be etiologically related to the physiological effects of some kind of medical illness. It can't be merely an emotional reaction to a diagnosis, and it has to cause impairment. Specifiers can include with depressive features, with manic features, or with mixed features. It cannot be due to substances, and of course, it cannot be better accounted for by any other mental disorder that the person may be presenting with. Common causes of mood disorder due to general medical condition include an endocrine problem, malignancies, infections, or neurological problems. Finally, a person could meet criteria for a substance-induced mood disorder. So this mood disorder is judged to be etiologically related to the physiologic effects of some kind of substance. And it's got to cause impairment, obviously. Specifiers include with depressed features, with manic features, with mixed features, onset during intoxication, and onset during withdrawal. This can't be better accounted for by another mental disorder as usual, and it can't be due to any general medical condition. Common causes of substance-induced mood disorder include medications and drugs of abuse. And then the etiology of mood disorders, let's talk about that. That includes neurobiological factors, social factors, personality factors, psychological factors, and even spiritual factors. So let's take a look at each of these. Neurobiological factors we can look at include genetics, neurotransmitters, what can be observed in brain imaging, and the neuroendocrine system. Well, let's take a look at each of these factors in turn. Okay, so first let's look at genetic factors. While heritability estimates for bipolar are very high, 93% in fact, heritability estimates for major depressive disorder are lower, but they're still significant at around 37%. And interestingly, heritability estimates are higher for women than they are for men. So one noted genetic factor is the DRD4.2 gene, which has been known to influence dopamine functioning. The DRD4.2 gene appears to be related to major depressive disorder. However, it's more likely that depression is not impacted by some single gene alone, but instead it's impacted by how multiple genes may work together to influence the way that people regulate their emotions. There's a lot of research in progress to identify specific genes that might be involved in depression, but I want you to know that the results of most of these studies fail to replicate what has been previously found. So at this time, we don't have a definitive answer on the specific genetic factors that predict depression. But what we do know is that neurotransmitter levels are different in people with depression. So norepinephrine, dopamine, serotonin, especially decreased sensitivity of postsynaptic neurons, and second messengers or G proteins are all impacted and all impact depression. So what do brain scans tell us about depression? Well, the amygdala, which establishes broader associations of a particular memory, like what preceded that memory and stuff, it assesses the emotional importance of stimulus, and amygdala activity is increased in major depressive disorder. But the hippocampus, which involves storing and accessing specific details, in other words, memory retrieval, it's down in major depressive disorder in response to emotional stimuli. The prefrontal cortex, which helps us focus on a situation at hand and execute an appropriate action plan, is down in major depressive disorder. And then the subgenial anterior cingulate is also up in major depressive disorder. So basically, the brain is oversensitive to emotionally relevant stimuli, and emotional regulation is impaired. By the way, the brain looks very similar to this in bipolar disorder. So here's a little more about the brain on depression. There's an overactive HPA axis in major depressive disorder, so too much cortisol is being pumped out. Excess cortisol has definitely been linked with depression. In resistant cases, cortisol does not suppress normally with dexamethasone, which it should do, and this is super important to recognize. Okay. Back to this. Obviously, the brain is not the only thing that's impacted by depression, right? And that also impacts depression. So social factors clearly play a part. 42 to 67% of people report a stressful life event in the year prior to depression onset. So, for example, like a romantic breakup, a loss of a job, the death of a loved one, something like that. These percentage findings were replicated in 12 studies across 6 different countries. So this seems to be a cross-cultural phenomenon. Lack of social support may be one reason that a stressor triggers depression. However, we also have to take into account interpersonal difficulties, right? So, for example, we know that high levels of expressed emotion by family members predict relapse to another depressive episode. The presence of marital conflict also predicts depression. But then there's some kind of a cycle at play here as well. The behavior of depressed people can lead to rejection by others. For example, excessive reassurance-seeking behavior, very low positive facial expressions, negative self-disclosures, slow speech, and long silences. All of that can lead to reduced social support as people can grow weary of these traits over time. Of course, personality also plays a part. So neuroticism, or the tendency to react with higher levels of negative affect, predicts the onset of depression. And then extroversion, which is associated with high levels of positive affect, can also predict depression in a converse direction. In other words, when extroversion is high, people tend to be less depressed. However, it's important to note that low extroversion does not always precede depression. Instead, it may be sort of like a constant factor that predisposes a person to developing depression when they experience a stressor. Okay, so there are also cognitive processes at play here. And the first is the existence of a negative triad, which is a negative view of self, of others, and of in the world in general, and of the future, self, others, and future. When a person experiences this negative triad, they tend to have negative schemas. In other words, they have an underlying tendency to view the world in a negative light, and they also tend to have negative cognitive biases. So they tend to process info that they're taking in a more negative way. This is that quintessential glass is half empty bias. So let's explore the connection between a few things, between learned helplessness, locus of control, and self-efficacy, and discover how these relate to depression and suicide. But first, we got to review memory and learning. So many people are familiar with the basics of behaviorism, which posits that people think, feel, and act because of what they have learned. Classical conditioning, most closely associated with Pavlov, pairs a neutral stimulus with a naturally occurring phenomenon. So most famously, Pavlov paired the neutral stimulus of a bell with the naturally occurring phenomenon that dogs tend to salivate when food is presented to them. Eventually, dogs salivated to the sound of the bell even when the food wasn't present. Operant conditioning, most closely associated with Skinner, works off the premise of reinforcement, which increases a behavior, and punishment, which decreases a behavior. Rats and pigeons were trained to successfully navigate mazes through the use of reinforcement and punishment. And then Bandura is most closely associated with social learning theory. So we don't just learn through direct experience, we can also learn by watching others have their behaviors rewarded or punished. So learned helplessness involves the cognitive, motivational, and emotional deficits that follow a perceived lack of control. In the original learned helplessness experiments, harnessed dogs were subjected to a series of electric shocks from which they could not escape. At first, the animals squirmed and they tried to escape, but they soon came to accept that they could do nothing to avoid those awful shocks. So then, after several trials of inescapable electric shock, the dogs were placed in an avoidance learning situation. That is, in a situation in which they again received electric shocks, but this time there was an easy way for them to escape. Whenever a signal sounded, the dogs could avoid the electric shocks by simply jumping over a small partition to the other side of a shuttle box depicted here. Naturally, dogs that had not gone through the earlier shock experience quickly learned to leap over the barrier to safety whenever they heard that signal. But researchers were really surprised by the response of the dogs that had first gone through the inescapable shock experience, because these dogs ran around for a few seconds after the shock came on, but then they stopped moving. Researchers said, to our surprise, it lay down and quietly whined. After 1 minute of this, we turned the shock off. The dog had failed to cross the barrier and had not escaped from the shock. So what had happened to these dogs? According to researchers, the animals had learned that they were helpless. Okay, so let's watch a very good film depiction of learned helplessness.
Nice work, pal.
At the first sign of trouble, I'll give you a signal.
Gaga! Gigi!
You mean like Crane does?
Yeah.
Excuse me, when have I ever made that noise?
Master Ox! Master! The ferocious Master Croc! And Master Storming Ox. Oh, I can't believe we're rescuing actual legends of Kung Fu. We're gonna free you from those bonds of injustice, no problem. Gotta be a key around here. No, they wouldn't leave a key around here. Yeah! Oh, good, you found it. Come on, you guys, yeah! We're coming for you, Shen! Woohoo! Woohoo! Woo! Guys, are we going or not? Do you want to meet us there later? I mean, you do want to take back your city, right?
Of course we do. But if we stand up to Shin, he will turn the weapon on the city.
Listen to yourself. You're protecting Gongman City by not protecting Gongman City? If we all fight together...
Then the weapon would kill everyone.
Oh, would it? Then we use a sneak attack. We get inside and then...
And then you will be stopped by the unstoppable weapon.
Nothing's unstoppable except for me when I'm stopping you from telling me something's unstoppable. Master Ox, I'm not letting you stay in this cell.
I'd like to see you get me out.
You guys see that? It's called being awesome. Come on, whatever happened to being heroes?
The only hero in this town is the dead one.
Like I said, you are not getting me out of the cell.
Yes! Woohoo! All right, let's go!
I get the top bunk.
It's time to surrender, Panda. Kung Fu is dead.
Kung Fu is dead. Fine! You stay in your prison of fear, with bars made of hopelessness, and all you get are 3 square meals a day of shame.
With despair for dessert.
We'll take on Shen, and prove to all those who are hungry for justice and honor that Kung Fu still lives. Yeah.
Okay, so even though they could escape, even though help had come, they had chosen to stay trapped inside their prison of fear and despair and shame. And it was because of what they had learned. They had learned that there was nothing good that they could do to keep themselves and others safe. And so they simply gave up. So depression sometimes develops in a manner similar to learned helplessness. People perceive a lack of control over important parts of their lives, and then they inappropriately generalize that perception to all other situations. So, for example, research participants who find that they can't control relatively simple lab tasks, like escaping like an irritating noise, they show significant increases in depressed feelings. Locus of control is a personality trait that divides people along a continuum according to the extent to which they believe that what happens to them and what happens to others is controllable, basically. So people who have learned helplessness tend to have a more external locus of control. That is, they have learned that they're powerless to make an impact on their own worlds. They've learned that outcomes are all outside of their control. Keep in mind that learning experienced early in life tends to more thoroughly pervade a person's life. So in other words, people who are survivors of childhood trauma, especially ongoing childhood trauma, are likely to develop complex PTSD and also, of course, to develop depression. So here are a few facts linking locus of control with depression. Researchers have found that, with a few exceptions, people with an internal locus of control tend to be happier than people with an external locus of control. It makes sense, right? People suffering from psychological disorders tend to have more of an external locus of control than an internal locus of control. Locus of control clearly impacts depression. So one review found an average correlation of 0.31 between locus of control scores and measures of depression, with external scores associated, obviously, with higher levels of depression. As a general rule, clients tend to become more internal in their control locus as they pass through successful psychotherapy, which is a really good thing. Okay. Just as external locus of control has been linked with depression, it has also been linked with suicide risk. So in one study, people who had recently attempted suicide were asked to relive the events that took place immediately before their suicide attempt. People were left alone with a tape recorder, and they were asked to describe in the present tense what had happened to them during this time. So I am feeling more sad. I am moving toward suicide. Analysis of the recordings revealed that people described themselves in more external terms as they became more and more suicidal. Researchers have found that people tend to experience an increase of events outside of their control just prior to a suicide attempt. And similarly, people become increasingly external in their locus of control as they become increasingly suicidal. And then finally, external adolescents and college students report more suicidal thoughts than adolescents and college students with internal locus of control. Hopefully, you've begun to tie all these different factors together to understand what contributes to depression and what causes depression to persist and to worsen. In the next video, I'm going to share with you a whole myriad of different technique options for treating depression. But for now, I want to thank you for your attention to this presentation.